I'm going to speak for about 25 minutes or so, and I'm just going to give you an overview of the field of violence and mental disorder. There's been some interesting new research in the last 10 years, and I'm going to try and summarize that and also give us a clinical, something useful clinically about how we can improve assessment, treatment. But I'm going to start off with the sort of basic questions. In violence and mental disorder, what are the risks? I'm going to show you that the risks are increased, but it's still a minority of patients that perpetrate violence. I'm going to look at a sort of key question. Is the association that we see between violence and mental disorder, is it causal, or is it explained by other factors, such as substance misuse or poverty? Then I'm going to look at whether we can improve assessment of patients for violence, and finally, what clinical implications there are, what we can do clinically in terms of improving assessment and treatment. So that's a sort of overview. Okay, so I start with the WHO report, and what's interesting about the World Health Organization report is it's focusing on violence as a public health problem. So public health has said very clearly that violence is a problem for us. It creates a lot of costs for healthcare, and many people die, but actually many more people suffer long-term consequences of violence in terms of morbidity, physical and psychiatric morbidity. These are the consequences of violence for people. But what's interesting about the report is it doesn't mention psychiatry at all anywhere. I mean, it's very, very light on psychiatry. And so actually, a lot of the field has not caught up, I think, with the evidence, not just the WHO report, but a lot of criminology doesn't acknowledge the potential role of psychiatry in trying to solve violence and improve prevention of violence. So here's a slide. It gives you a snapshot of absolute risks. So within 5 years of diagnosis, what is the risk of perpetrating violence? And this is quite a high threshold for violence. So this is a crime. So this is something that's recorded by the police. And this is work done in Sweden, where there are very good records that can link patients to crime records. And as you can see, if you look at two outcomes, violence and suicide, they're both increased to the general population, which is here. So the general population over 5 years, you'd expect around 1% of people of similar age, similar gender to these cohorts. But as you can see in schizophrenia, it's increased, it's nearly 8%. In bipolar disorder, it's also increased, it's 3%. And in depression, interesting enough, it's also increased, and people haven't really acknowledged that depression does increase your risk slightly, but still it's a significant increase in risk. The other takeaway message from this slide is that this still is a minority of people. So more than 90% of people, there is no violent acts. So there's a difficult message for the press and the public that we have an increased risk, but still it only relates to a minority of patients, and a small minority of patients, less than 1 in 10. So it's a very difficult message. It's not a very easy thing to explain. It's up, it's very high, because that's not right, but also it's not low and insignificant and not important. It's somewhere in the middle. And I compare suicide, so you can see, for instance, in depression, we're very focused on suicide assessment, suicide risk, but actually the violence risk is much higher. And so there needs to be some awareness that these are adverse outcomes, and they're both really important, not just one. The rates of violence also depend on where you are in the patient pathway. So this is a slide, it's a bit busy, but it's a slide saying that actually where you are in the patient pathway does determine the rates of violence. So they can be quite high in first episode psychosis, but people in treatment, it's much lower. This is a US review, so the rates are probably higher than in countries like Italy. Now that was absolute risk. Now this is relative risks. So here you compare everything to the general population, which is 1, and everything on the right of this line means that it's an increased relative risk. And this is a review of reviews we just published, and it says that basically for all the mental disorders, I mean, epilepsy is a neuropsychiatric disorder. It's the only one that isn't increased risk. But all the others, there's an increased risk. And this is relative to the general population. So this is where you talk about relative risks. Interestingly, I've put some other domains which attract a lot of interest and research, but as you can see, they're not as strong as the neuropsychiatric risk factors in terms of relative risks. So psychiatry has a lot of the modifiable risk factors for violence, and it seems to be across all the disorders. One thing to bear in mind is that quality of the evidence is variable, and the best evidence is for antisocial personality disorder, which is no surprise, but also for the psychoses. These are the two mental disorders where the quality of the evidence is the best. There is evidence for all the mental disorders, but in terms of quality, the studies which are large, which are well adjusted, which use long follow-up periods, very careful measurement, these are the two where the best quality evidence is. So the second question, I mean, I've tried to show that the relative and the absolute risk are increased. The second question, is it causal? So, okay, maybe increased, but it might be because people with psychiatric disorders are in poverty or subject to they're victimized themselves quite heavily. So is it actually a causal? And here, we can rely on different types of evidence. I mean, there's a sort of hierarchy of evidence, and the best evidence is the randomized controlled trial. So if you treat the mental disorder, the violence rate goes back down to nothing, basically. But then there's a hierarchy, and the ecological evidence is, is the least strong, and then it moves down. And basically, in this area, the evidence does suggest causality. So if you put all of this together, you get a picture that is consistent with causality for mental disorder being a cause of violence, an independent cause, not explained by other factors. So I'll talk you through some of them. So if you look at schizophrenia, these are all the studies done looking at the risk of violence in people with schizophrenia compared to the general population. And the point about it is every single study done shows an increased risk. And this is basically a consistent line of evidence. So it's one of the factors of causality, that you have a consistent line of evidence irrespective of how you measure the outcome, how you measure the schizophrenia, how long your outcome is. It's all consistent. 20 studies when we looked at it a few years ago. The other thing you can do is you can compare people with schizophrenia to their siblings who don't have schizophrenia. And this is a very powerful way to try and adjust for lots of factors that people share in common. So the idea here is that if you have a brother who doesn't have schizophrenia, they will share some of the family factors, so the same socioeconomic class. If there's been any violence in childhood or maltreatment, this would be shared. So if there's a difference between the person with schizophrenia and their brother, it's usually men, then we can attribute that to the schizophrenia, because that's the main thing that differs between the two siblings, if the brother doesn't have schizophrenia. And there's been 2 sibling studies, and they both show an increased rate of violence in the sibling who has schizophrenia compared to the sibling who doesn't. And this is one done in Israel. There's also one done in Sweden. There's only 2, but they both show very similar increased odds of violence. And this is violent crime, again, so it's a very high threshold. Now, this is the most powerful evidence, I think, because it's from randomized controlled trials. And here, these are randomized controlled trials in schizophrenia. And this was a very well-known review published in The Lancet, Stefan Loch's group. And what they did is they looked at all the randomized controlled trials that measured violence after treatment. So this is one arm gets treatment, one arm gets placebo. The arm that gets treatment has a reduction in violence, and that's quite a large reduction. I mean, it's small numbers, but still, that's nearly 70% reduction in violence. And that's very strong evidence of causality. You treat the symptoms, and the outcome is reduced. And then finally, we've done some studies using the real-world effects of medication, and this is looking at people when they're on medication compared to the same person when they're off medication. And what we've shown is that when you're on the medication, your rates of violence go down. So this is the same person acting as their own control, and it's a way that you can look at the effects of medication in the real world. And so this is the group with schizophrenia. I mean, I've highlighted bipolar disorder, but it doesn't really matter. So schizophrenia shows that if you're an antipsychotic, it's 35% reduction in violent incidents when you're on the antipsychotic compared to when you're not. So this is another sort of treatment study to show, I think, the effect of treatment on reducing risk. So in summary, you have an increased risk across a range of disorders. The absolute risks can be high. So in some disorders, in the men, it's approaching 10%, but most of the time it's below 10%. And I think the evidence from the epidemiology is consistent with causality, all the way from observational studies to treatment studies. You have the same pattern emerging. So the next question is, so what? So we know that there's a problem here. What can we do about it? Well, I mean, one thing is to wake up to the evidence. So this is an editorial published by a very well-known forensic psychiatrist saying that, you know, it's also, I mean, one thing is to acknowledge as a profession that this is an issue that we have to deal with, because actually in many countries around the world, and even within countries, there's a lot of psychiatrists who don't want to face up to this. It's not a very nice a message to share with patients and the public. I mean, the second element of this, of course, and this is a newspaper headline. We get headlines like this probably every month of a stranger being attacked, and this is with a screwdriver. After release from hospital. I mean, this is the sort of worst headline for psychiatry. And I suppose, you know, it's very important not just to acknowledge the problem, but also to prevent it, because these sorts of headlines are very damaging to the image of psychiatry, stigma for patients, funding probably for services as well. So these sort of incidents have to stop, really, for us to improve, I think, on a number of different levels, including stigma. So can we improve assessment, and what are the clinical implications? So this is some area of work that I've been interested in the last few years. Can we improve assessment? I mean, currently, many approaches to risk assessment are quite subjective. Some of them are also very resource intensive. By that I mean take a long period of time. You have to fill in a very long questionnaire. Takes many hours. You have to be trained by some guru who gets flown in from North America usually. And the methods are a little bit old-fashioned. There's lots of false positives. And so the question I've been interested in is, you know, can this be improved? Are there more efficient ways of doing risk assessment? Can it act as something to improve or assist clinical decision-making? Because ultimately, clinical decision-making will be still the most important element of any risk assessment. So one way of looking at this, I mean, one precedent for this is the most famous and most widely used tool in medicine for risk prediction is Framingham Heart Score. So this is a very simple tool. You go online, it's free of charge. You fill in some risk markers, age, gender, cholesterol, HDL cholesterol, being a smoker, systolic blood pressure, and it gives you a 10-year risk score. So it says in 10 years your risk is 2% or 5% or 10%. If it's 10% or more, you are supposed to consider a statin with your doctor, or at least think about alternatives such as more exercise and change to your diet. So with a simple calculator, it enables you as a clinician, but also the patient, to have an informed discussion about what are the possible things you can do to improve your health and prevent the outcome, which is in this case a heart attack. And this is the most successful tool in medicine. It's widely used. There's all sorts of variations on this for people with diabetes, people with renal disease. In the UK, we have a variation on it called Q-risk, and the UK one has some ethnicity factors, because we've shown in the UK that some ethnic groups have higher risks. And so this is something that I've been interested in thinking about, whether it's possible in psychiatry to do something similar. The other, of course, risk thing that we do a lot is we look at weather forecasts. This is Torino today, 12% rain. And what's interesting about this is a weather forecast, and it uses a slightly different approach. It's not just yes or no, high risk, low risk. It's saying percentage. It's giving you a probability score. And based on this probability score, you can make a decision if you're going to take an umbrella or a coat. And we're now used to this. I mean, this is part of the way we live our lives in many different areas, from insurance to weather. We're used to looking with probability scores, not just the simple, is it going to rain or is it not going to rain? I mean, that's just a bit simplistic. Now with big data, we can give a more precise estimate of the percentage chance of it raining. And what this means is that in 100 days, like today, 15 of those days there'll be a rain. In 100 days like today. But it doesn't, that's what it means. And that, I think most people, or at least people like us, I think, can understand what that means in terms of how to make a decision. So what we've been doing is trying to do this. And we've used Sweden, because Sweden has these linked databases. We use very large numbers, so 75,000 people. We looked at everyone with schizophrenia and bipolar disorder in Sweden over 10 years, and we split it up into a sample where we tried to develop a model, and then we tested it in what's called a validation sample. And we developed it in one part of the country, which is in red, and we validated it in another part of the country, which is in grey. And we looked at risk factors, and I won't talk very much about the detail, but you're welcome to come and speak to me about the detail. We looked at 4 different types of risk factors, and we put them into the model and looked at the outcome of violent crime, which is a very high threshold, of course, but it provides you with a risk score for violent crime. And we looked at these risk factors. These were the proportions of these risk factors that were present in our sample, but these were the risk factors we put in. We chose these risk factors because we wanted factors which were easy to measure, which were mostly collected by most people. Most clinicians will collect this information during the first or second assessments of patient groups. So we wanted factors that were not complicated, that you needed an extra instrument and some extra training, take a long time. We wanted to pick factors that were straightforward to use. And we put them into a model and we tested them. And these were the ones that remained independent in the model. So these were the ones that added something. And we converted this into a risk calculator. So this is a risk calculator. These are some of the metrics or performance measures of the risk calculator. I won't talk a lot about them, but basically the risk calculator is a very good way of screening out people. So if you want a way of saying, I think this patient is low risk, I don't have to worry, I don't have to follow them up every week or put them in a special forensic unit. This is a very effective way of screening out people. in terms of people who are high risk, well, it does identify about 2/3 of people, so that's what the sensitivity it is. So of the people who have committed a crime, the risk calculator does identify 2/3, but that's using categorical scores, yes, high or low. We've also got a probability score in the calculator, so it does both. So a bit like the weather, it tells you if someone is, what the percentage chance of that person is of committing a violent crime in the next year. It's a 1-year follow-up. And it's freely available. This is it. You can just look at it now if you want to. There's very drop-down menus, and you can fill it in, and it gives you a probability score and then a categorical yes/no based on a 5% cutoff, which is high. So basically, I mean, this is in a way, sort of pilot experiment. It is possible to do risk prediction better, I think, using big data and better methods. It's very important whenever you look at any of these calculators to see if it's been externally validated. So has this tool, has it actually been ever validated in a new sample? My view is that these tools can really only support clinical decision-making. They need to work together. It's not either or. There's no question here of replacing people with robots. It's a question of supplementing human judgment with something which can help anchor your decision-making in some evidence, question your decision-making. But ultimately, the clinical decision-making will be will guide the treatment going forward. So what do I think about sort of clinical implications of all this? Well, I think in terms of assessment, I mean, it's the normal things that we do. And if anything, what the research evidence has shown is that there are some specific risk factors that it is important to ask questions about. And among them are obviously history of violence. The family history seems to be important. It's a marker of future risk. Drug and alcohol history, which is, again, pretty well known, and adherence. So previous adherence, engagement with services is an important risk marker. If there is previous violence, a little bit about what's going on with the previous violence, particularly the mental state at the time of the violence, and victimization is important because it does seem to be a strong overlap. So it's not just that psychiatric patients are victimized, but actually there's an overlap that people who are victimized then also perpetrate violent acts, and it goes both ways. It's not just one direction. In terms of mental state examination, I mean, the tools don't really do this. These are much more nuanced clinical items, but there are some particular symptoms which seem to be important to focus on, including persecutory delusions, especially if there's an affective component to them. So if you have a delusion but it doesn't make you angry, that's not so dangerous as a delusion that really makes you angry, because the anger will partly be motivating you to do something about it. And there's a range of others which are not very specific, but important to think about. And finally, I mean, I think risk assessment does have a role. I think particularly if you're uncertain about the risk, or it's thought to be high and you want to double check that, or actually you just want another way of anchoring your clinical decision making with some support from a different direction, then you can use a tool to supplement that. And finally, I mean, what is the link to interventions? So what are the interventions? If you do identify someone as being higher risk, what can you do about it? Well, there is some information. I mean, most of it is just good clinical practice, but if there is anything specific, it's probably that you would move to clozapine a little bit earlier than you otherwise would, because clozapine does seem to have a specific anti-aggressive effect. I mean, there's the famous trial to show that it also reduces suicide risk, but there is now some observational evidence and smaller studies to show that clozapine has a specific anti-aggressive effect. And that's probably the same mechanism. It's probably around impulsivity, that it does something specific to impulsivity, which reduces suicide risk and violence risk. The other thing you might consider doing also is move people a bit earlier onto depot medication, because adherence is important. Finally, I mean, secondly, and this is very difficult, is treatment of comorbid substance abuse. It's very easy to say treat comorbid substance abuse, very difficult to do in practice. But nevertheless, we know it's a risk factor, particularly comorbid substance abuse. And you know, if someone is considered high risk, then a range of possible interventions, even pharmacological interventions, might be considered. I mean, it's very rare for people to use a camprosate in people with psychosis, but there's no reason not to use it, I think, if all the safety issues are dealt with. Adherence therapies. So these are just psychological therapies to improve adherence, everywhere from psychoeducation to simplifying dosing regimes. You know, try and give people once a day regimens, reminders, ways of checking up their adherence. And the other thing is, if someone is identified as high risk, is just more frequent follow-up, more monitoring. Then you can intervene more quickly if things are going wrong. And there isn't much strong evidence for assertive community treatment. So that's it, really. I've tried to show that absolute and relative risks are clearly increased. And explaining that message is not straightforward. It's still a minority of patients, but it's increased. And there's some heterogeneity, some variation, some disorders a little bit more than other disorders, but there is a pattern that most neuropsychiatric disorders have an increased risk. Is the association causal? Well, I think yes, for severe mental illness. Strong evidence from randomized controlled trials, and then lower forms of evidence as well. It's not explained only by social situations people are in. It's actually causally related to the illness. Can we improve assessment? I think so. I mean, knowledge of the risk factors can help, but also I think some simple scalable tools can help. And the clinical implications, well, here it's good clinical practice, and there are some modifiable risk factors that can be focused on. They mainly relate to symptoms and comorbidity, which generally applies to all good clinical care, but it might be optimized for people with high risk.